They will give an overview and then we'll discuss. Okay, good morning. Sorry, the presenter is stuck in some emergency hospital, so he cannot present. So Dr. Utpal De is with us today. Dr. Utpal De is Professor of Surgery at NRS Medical College. Dr. De will give us an overview of liver Hydatid and its different forms of management with emphasis on current concept in Hydatid management. And then at the end, we can discuss some issues with our resident who are attending. Dr. De, please start, because Hydatid is a common disease in the hospital exam, and a student has to face a typical case of Hydatid in the liver. Dr. De is giving an overview.
Good morning, everyone. Today, I'll give you an overview about Hydatid cyst, because Hydatid cyst, as you know, what we used to study nowadays, there has been a lot of change. Now, what has happened is, in the 21st century, there has been a paradigm shift in the management of Hydatid cyst. New strains have come up, and the management is basically now in the lines of malignancy. Why it's in the lines of malignancy? Because Hydatid cyst has a natural tendency to recur. Hydatid cyst has a tendency to spread to other organs, and Hydatid cyst is something which has got specific therapeutic applications apart from the surgeries of the yesteryears which we used to think about. Now, to come to the disease specific, it is mainly if you take into account the total management, the basic part is based on the pathophysiology, the microbiological aspects. Now, as a clinician, we usually get Hydatid cysts when they are large enough and they cause certain symptoms due to the pressure effects or invasion to adjacent organs. Now, if you look at the pathology of the Hydatid cyst is basically caused by strains of Echinococcus. So Echinococcus previously, as you know, it's a tapeworm. It's a genus. It's a species of the genus tapeworm. But then the typical tapeworm, which has got numerous proglottids, means the segments that is not there in the Hydatid cyst, which usually infects us. So mainly it is of the Echinococcus genus, and we used to know about two species. That is Echinococcus granulosus and Echinococcus multilocularis. That is what we used to know when we were students or we read microbiology. But with advancement and with the proteomic and genomic analysis, now it has been seen that even in the Echinococcus granulosus strains, there are so many varieties. And basically, what happens is sometimes we have also seen that when we give albendazole, some patients they respond, some patients they do not respond. So in this way also it behaves like a malignancy because it has got properties of immune invasion also, evasion also. So basically, the newer strains that have come up apart from Echinococcus granulosus and multilocularis are Echinococcus vogeli and Echinococcus arthoclitus. Now, these two strains together, they form a type of Hydatid cyst which is known as neotropical Hydatid. So this is basically, as you know, the worm, it has got a head, a neck, and a single proglottid. So that is the characteristic. And also, if you look the proglottid, which has got thousands of eggs in it, and these eggs are usually infected. Now, if you go into the worm itself, it is a hermaphrodite, means it has got both male and sex female organs in the worm itself, and its life cycle usually happens in two hosts. One is a definitive host and the other is an intermediate host. Now, the definitive host is usually obviously the dogs and the jackals. These are the definitive hosts. And the intermediate host, here in the definitive host, actually the sexual cycle it takes place, and in the intermediate host, that is the sheep, the rodents, here the asexual cycle usually takes place, and the cycle continues. Means the worms are expelled through the feces, and then what happens is they are ingested by the intermediate host, where the larvae they hatch and they convert into adult forms, and then they are shifted to the definitive post where the sexual cycle takes place and the cycle continues. Now, humans previously we thought was if humans were an intermediate host, so it got accidentally infected. So that is what we thought of. But now it has come out that even man can act as an intermediate host. And so this is what is a newer change that has been there in the 21st century. So humans usually get infected by accident, and then the worms are ingested. They go to the intestine from where the eggs they hatch into larvae, and these are then transported by means of the portal system into the liver. Here in the liver, they form typical cysts, which are trilaminated. As you all know, the inner is a terminal layer, and then we have a layer which is known as a ectocyst, endocyst, ectocyst, and a pericyst. So these are the walls of the cyst, and inside the this endocyst there are small cysts which are formed, which are nothing but the brood capsules, and they usually detach from the walls and float in the fluid of the cyst, which are known as hydatid sand. So, and if you look at a microscopy of those cyst walls, as it is typically described, it has a paintbrush type of appearance. Paintbrush means when you paint a wall with a brush, you find that there are numerous layers which are there. So that is a typical description of the cyst wall, and that is what is identified in the histopathology. So this is in brief about the microscopy and the microbiology of the organisms. And usually we get infected by stray dogs who roam about in our house. And but in case of multilocularis, the infective agent is usually the rodents or the rats. Now, the difference between Echinococcus multilocularis and cystic echinococcus is usually Echinococcus granulosus causes cystic echinococcus, and Echinococcus multilocularis, they cause a disease which is known as alveolar hydatid. Means there are multiple cysts which look like alveoli of the lungs. Now, the difference is the alveolar hydatids, they have a tendency to penetrate the adjacent organs. So that is much more dangerous. They can penetrate the bile ducts, they can penetrate the vessels, and it is akin to malignancy. And they cause an intense, intense reaction, fibrotic reaction, which is very common to malignancy also. In malignant tumors, as you all know, they cause a desmoplastic reaction. So this cyst also cause a fibrotic reaction, which usually surrounds the cyst. Now, this is in part an advantage to the person who is affected, because the cyst fluids cannot penetrate out of the whole cyst. Whereas in Echinococcus granulosus, there are numerous fissures through which the cyst fluids can leak out into the circulation. So, but in one way, this is good because this cyst fluid contains antigens, and if the cyst fluid leaks out into the circulation, they tend to develop antibodies. So, if you look at the serological test, which in our times we used to do by a Casoni's test, which is not done nowadays because of certain ethical issues, because those are usually taken from the animals which are injected into humans, and then they are seen. So that is not being done, and nowadays the serological test is done usually by ELISA technique. So this Echinococcus granulosus has got a higher sensitivity and specificity for detection by Echinococcus by ELISA than Echinococcus multilocularis. So based on this this background, now let us see what happens in a hydatid cyst. So as I said, once the cyst is ingested, it goes to the liver, and also it may go to other organs also, and they develop into typical cysts. Now, a problem is, do the cysts, once it gets infected, do they cause symptoms instantaneously? No. They have got a period of growth. So since infection to development of symptoms, the incubation period is pretty long. It takes 10 to 15 years, as it is written in textbook. And it has also been calculated that the growth of the cyst is 0.3 centimeters per year. And roughly when the cyst becomes 10 centimeter in size or 70% of the liver is involved, then only the symptoms they appear. So what symptoms appear? Symptoms usually are of two types. Mainly, these are based on the compression that it causes to the adjacent organ, adjacent structures. Adjacent structure means the bile duct. If it compresses the bile duct, patient will have jaundice. Apart from the first, let me tell you, if the cyst is large, it may cause a vague pain in the right hypochondria, right? And then with the compressive effects, the jaundice may appear. And and if the cyst ruptures, obviously there is a hypersensitivity reaction, which we all know. Now, based on these symptoms, that is, but one thing I must also say that Hydatid is not very much common in the younger age group. It usually occurs in the adult and older age group. That is what we usually find. Though it's not very specific, it is found in younger age group also. But usual age group is in the adult patients. Now, with these symptoms, now there are certain these are typical symptoms of Hydatid cyst. It may also present atypically also. Now, when we see these patients, now we have, and on clinical examination, what do we find? We find a hepatomegaly. So that is what we found. I'm not speaking about those cysts which are extrahepatic, because there are situations where extrahepatic cysts are also found, and they may present like any other cyst in the abdomen, like a mesenteric cyst. Okay, so or like an ovarian cyst. So these are the cysts which are extrahepatic without primarily involving the liver. So that is also possible. So it may be possible in a varied number of ways. Now, with these symptoms, when we examine the patient, typically we find a hepatomegaly. But on the first instance, Hydatid cyst does not come to our mind that yes, it is a Hydatid cyst. It is only on investigation that we find that there is a cyst in the liver, and ultrasonography can tell us definitely that yes, this is a Hydatid cyst, because on ultrasonography, there are certain features which are present, which is based on the cyst wall, the typical characteristics of the endocyst, the Hydatid sand. So everything, all these together, they give us an impression of a Hydatid cyst. Now, based on these ultrasound findings, there are certain classifications. The Garvey's classification is the commonest classification. In the one end of that, we have infected cyst, and the other end, we have a benign cyst. But now, the WHO has modified this Garvey's classification to a certain extent. Now, what they have done is there is an international working group on echinococcal disease. So they have modified it, and they have said that the Hydatid cyst or echinococcal cyst, or cystic echinococcosis, is graded into 5 categories. That is grade 1, grade 2, and then grade 3 has been divided into 2, 3A and 3B, and then we have 4 and 5. Now, what are these grades? These grades are nothing but they speak about the infectivity of the cyst. Now, grade 1 and grade 2 cysts are cysts which are infective in nature. Grade 3A and 3B are cysts which are transitional, means they are going from infective to a non-infective nature, and grade 4 and 5 cysts are usually cysts which are non-infective. They may have calcifications, might not have calcifications. Now, this is for cystic echinococcosis. But then, based on how we suppose when we treat patients with breast cancer, we say triple assessment. For Hydatid cyst also, we have a triple assessment. That is why I said it is akin to malignancy. Means it's triple assessment. What is this triple assessment? First is based on clinical features. Second is based on the investigative features. And third is based on serology. Now, suppose a patient has clinical features, but the radiologist, because there is also a question, as I said, that the USG can detect cysts, but there might be cysts which are very small in size. As I said, the incubation period is pretty long. So, this small cysts might sometimes be missed on ultrasonography. So, based on the clinical features, if radiology and serology is absent, then we say it might probably be a Hydatid cyst. If we find clinical features and radiology, but serology is negative, we say that it is possible that it could be a Hydatid cyst. And if the serology is positive and the others are negative, even if the others are negative, we say it is definitely a Hydatid. So this is what the international study group on Hydatid has recently classified cystic echinococcosis based on this. Now comes the question of the classification. Now, let me first tell you the other investigative modalities. The other investigative modalities which are coming up in a big way are the CT scan and the MRI. So these can also tell to a certain specificity and sensitivity about the possibility or the probability of Hydatid cyst. Now things are a bit different when we come to Echinococcus multilocularis, because Echinococcus multilocularis, or as you know, it is also known as malignant Hydatid. So the diagnosis is also based on a bit of a malignant type. Means, what do I mean by malignant type? Now, as you all know, that PET scan is a very good investigation for diagnosis of metastasis and malignancy. Now, what is seen in this Echinococcus multilocularis cyst is the periphery of this cyst have a high vascularity. So this is one disease where even in a non-malignant case, we can do a PET scan, and the PET scan can give us impression that yes, it could be a cystic Echinococcus multilocularis or a malignant Hydatid. Now the problem comes is based on this PET scan only, we cannot say that yes, it is a malignant Hydatid. So in addition, in these cases, we need to do a serological test. And compared to cystic echinococcus, Echinococcus multilocularis antigens are more antigenic, and a serological test sometimes is definitive and is an adjunct to PET scan for a definitive diagnosis. But still, when we have diagnosed that PET scan is a definite investigation which should be done in case of malignant Hydatid or alveolar Hydatid to plan our management. Now let us come one by one. Now suppose the patient has got cystic echinococcus. We have done an ultrasound, we have classified it, and then we find it is type 1 and type 2. Now as you all know, for type 1 and type 2 cysts, it is mainly these are infected cysts. So do we go in jumping for surgery? No. In these cases, we need to treat. So there are two things which are important. Here, the size of the cyst is important and the infectivity is important. So if the size of the cyst is less than 5 centimeters and if the cyst is found to be infective, we start with the benzimidazole, that is mebendazole or albendazole. So we give that and then we follow up these patients. Now, for type 2 cysts also, who are more than 5 centimeters, what we can do here, there is a bit of gray area. Many kinds of treatments are available based on if the patient has got compressive symptoms and if the cyst is more than 5 centimeters. We have 3 options. What are these options? Number one is we can do a pair therapy. What is pair? We perforate, we inject, then we aspirate, and then again we re-inject. So this is what is pair. We can do a pair therapy. Now this pair therapy has now further been advanced. Now there is another therapy which is known as MOCAT. What is that? That is modified catheter insertion technique. In this technique, what we do is we put in a catheter inside the cyst. What is the difference of this with pair? The difference is in pair, we only inject and re-aspirate, but we cannot take a biopsy from the cyst wall. But in a modified catheter technique, when we insert a catheter, we can take the cyst endocyst out. So it is a type of a surgery we used to do in our times where we used to remove only the endocyst. So that is the difference between modified catheter and a paired technique. Now, we all know what is usually injected in care. Two most important drugs which are usually used are 20% hypertonic saline or 95% ethanol. But there should be a care when we usually inject it. We need to see whether it has any communication with the bile duct. Now, if there is a communication with the bile duct, then we need to be very careful, because if we give these drugs, they may induce cholangitis and also later on fibrosis of the bile duct. So in the MOCAT therapy, what we can also do is, if we find that there is a communication with the bile duct, then in adjunct to that, what we can do is, because once we do that, if there is a communication, then there is every chance of a fistula formation. That means if the catheter is there, continuous bile is going to drain. So how do we need to control this? So in addition to this, what we can do is we can do an ERCP and then place a stent. So that will solve the issue of this biliary communication. So this is one part. The other part is we can go in for a surgery. And nowadays, what is said is the definite surgery is total cystectomy. It is not endocystectomy or pericystectomy, total cystectomy. And that too by not breaking the cyst. That is very important. So we need to remove the cyst in toto, and we need to remove the cyst entirely. We need not cause, or we should not cause killers. Now, one question arises. It's basically a decade, or it is basically times of laparoscopy. So, do we do laparoscopy? Yes, we can do laparoscopy. But when we do laparoscopy, we need to take all the precautions that needs to be taken during open surgery. Means the precautions of spillage, okay, and we need to see that there is no cyst wall that is left behind. So all these things, whatever we do in open surgery, that we need to take care of. Now, previously we used to study that when we did a partial cystectomy, we used to have questions being asked that what do we need to do with the cavity? So there were many options, means omental plugging, capitonate. So all these concepts are for the yesteryear. So these concepts are gone now. There is no question regarding keeping the cyst, whether it is the ectocyst, pericyst, there is no question of keeping the cyst. We need to remove the cyst. And even today, now the concept has, like other surgery, the concept of hepatectomy and transplantation for hydatid cyst has also come in. Now, this transplantation is not for this cystic echinococcus. It is mainly for the malignant hydatid or the alveolar hydatid. I will come to it later. So this is for type 1 and type 2 cyst. Now, for type 3A and 3B cyst, now this is also a gray area what we need to do, because these are transitional cysts. So there are two modalities. We can wait and watch, or what we can do is we can give a course of albendazole prior to the surgery. That is 1 week prior to surgery. We can give albendazole in the dose of 15 milligram per kg body weight, and then we can wait and watch and see as to what the cyst happens. Or if the cysts are less than 10 centimeters or more than 5 centimeters, we can go in for surgery and totally remove the cyst. Now, for grade 4 and grade 5 cysts, surgery is usually not done until and unless there is compulsion to do that. So, because those are dead cysts, they do not cause any harm. But if there is some compulsion to do it, then we need to do it. So, this is, and then another question comes is, during surgery, suppose there is some spillage, then what do we do? So, for cystic echinococcus, we need to give a post-operative course of albendazole. That is a systemic therapy. And for how many days? For usually 2 months. So that is the WHO recommendation. Now coming to the alveolar hydatid, as I said, the alveolar hydatid is usually diagnosed by PET scan. Now by PET scan, when we diagnose alveolar hydatid, we have two classifications. One is the infective form, the other is the non-infective form. For the infective form, what we do is we usually give albendazole therapy initially, and if albendazole therapy fails, then the question is pretty tough. What we need to do is we need to either do a hepatectomy, and if it is involving both lobes of the liver, because the mortality rate in case of alveolar hydatid is very high. Now, reports have been there for the incidence of mortality is more than 90% in countries who are in which it is very prevalent. But for cystic echinococcus, the mortality rate is pretty low. It is 2 to 3%. That is what is said in the literature. So for alveolar hydatid, then these things need to be done. And even it's a very difficult surgery. When someone has performed surgery for alveolar hydatid will come to know how difficult it is because the adjacent organs are involved. So I forgot to mention one thing is, now as cystic echinococcus is graded based on grade 1, 2, 3, 4, 5, the alveolar hydatid is classified based on PNM classification. That is akin to PNM classification in malignancy. What does P stands for? P stands for the parasitic infection. N stands for nearby organ involvement, and N stands for metastasis. So based on the typically like what is seen in PNM classification, we have a PNM classification in which there are stages, stage 1, stage 2, stage 3, and stage 4. So these are the stages, and based on that stages, usually the management is determined, and the management here is basically if you want to do a surgery, just a limited surgery of a hepatectomy or a limited surgery by removing the cyst is not feasible in these cases. And here we need to do an extensive surgery where transplantation or hepatectomy comes into the role of these two things coming, but then it is very, means as I am saying that, but it is one who has operated knows how difficult it is because of the extensive additions that are present in this. Now, for alveolar echinococcus, what we need to do is we need to give albendazole therapy, and that albendazole therapy should be for a minimum period of 2 years. So that is what is recommended. So this is in just about the matter. There are many other issues which are there, which has recently come up. Now these, if I tell a bit more about the recent advances, then you will find that in the recent advances nowadays, the hydatid DNA has been studied. There are proteomics and genomic studies which have been done, and like malignancy, where we give targeted therapies, there are newer drugs which are, because as I said, the like tumor immunity, hydatid also has got a typical immunological characteristics. Some hydatids, they are detected by immune surveillance, but there are certain hydatids which are immune evasive. That means they cannot be detected by our natural ELISA tests. So based on this, what they do nowadays is they do a PCR assay, and usually if you look at the cystic hydatids, they are of 10 varieties, and so you need to know which variety it is, and then you give a specific drug. There are other benzimidazoles which have come in, and we can give that specific drug. Now, for alveolar hydatid also, the newer therapies which have come in are in the forms of vaccines. So they have developed vaccines. The antigenic structure has been determined by proteomics, and they either give same type of antibodies which are present, which are monoclonal antibodies to say. Those can be given, but these are very recent concepts. Vaccines are also coming up now, but another thing which we, apart from, so this is an overall gist about the management. So management basically consists of, in one part there is conservative management, then we have a limited management in the form of this pair and hemocat, and then we have surgery in the form of either total cystectomy, hepatectomy, or transplantation, and then we move forward to immune therapies, then we have systemic therapies, then we have specific targeted therapies, and then we have vaccines. So this is the treatment of hydatid cyst in 21st century. So there is a lot of research which is going on, and I can share a topic. I do not have it right with me, but I will share it. There's a very good article which has come out, basically based on what hydatid cyst, how hydatid cyst is being looked at, and the WHO is contemplating to eradicate hydatid cyst by 2050. Currently, there are only 2 countries where hydatid cyst has been eliminated. One is New Zealand, the other is Tasmania. So these are the two areas where it is eradicated. But then who has proposed means there is a multi-pronged approach, multi-dimensional therapies, not only to humans but also to the predators and preys that usually infect us. So there's it's a very good article I will share with you. You can go through it, and all whatever I have said today, I think most of it is included there, and that is what is the current management of Hydatid cyst. And also, as I said, it is now looked like a malignant disease. And like a malignant disease, we need to have a specific surveillance for this, and we need to have a definite protocol. So it is also given the schedule of the protocol, what things need to be investigated during the follow-up, what tests are to be done, what radiological diagnosis or what radiological investigations need to be done. So everything is given in that in the form of an algorithm also and text also. So you can go through it. So what I mean to say, the Hydatid disease of the years, there has been a paradigm shift, and there is basically it's a new disease now, and a lot of things are into research like any other subject. So things are becoming much more tougher, and I think days are not far away when you will find that Hydatid cyst treatment and management will become also a specialty in itself. So with these few words, this is rough gist about the management and about basically about Hydatid cyst. Now, if someone has any questions or sir wants to give some inputs to it.
Actually, Dr. Thank you, Dr. De, for giving a good overview of the whole of Hydatid cyst, including its recent management. But I like to emphasize few points on the clinical presentation. Because in the exam, most of the time, you find patient is presenting with a mass in relation to the right or left of the liver. And in exam, don't try to say that it is a cystic swelling, showing fluctuation, getting hydrated thrill, because most of the examiner does not agree to these findings. In a abdominal swelling, it is difficult to say that cyst is a fluctuant swelling. It is difficult to say is having a typical cystic feel. Most of the time, hydrated cyst in the liver is intrahepatic, and you cannot appreciate that cyst is a typical soft cystic in feel. It can be even a firm feel. It should not be hard in feel like a malignant deposit. So that is one. Second, don't try to elicit hydrated thrill in a classical case of even hydrated cyst. So these are not required. The point is, you find a hepatomegaly, a smooth swelling in the liver, either in the left or right of the liver, and then you say probably a solitary lesion in the liver, and patient is not having much of symptoms, just a dull ache pain. So most common diagnosis may be hydatid cyst. That is the way you should approach. Next is, as Dr. De has described, once you are asked about this justification of diagnosis, you justify the diagnosis taking some points from history and some points from examination. And then when you are asked about how you proceed with this patient, the most important part is ultrasound. And Dr. De has described, there is one classical way of describing the ultrasound finding with CL, C1, C2, C3, and then now it is being modified, but you can stick to the even previous classification of ultrasound appearance of the cyst. So you should be very conversant with how the cysts are classified based on the imaging study. That is one. Second is, in the test, there are some serological tests where there are a lot of tests being mentioned in the book. It did not mention all. The best test is ELISA test for hydatid antigen, and there are some tests where you did the antibody to hydatid antigen. So these are the two basic tests which are required for diagnosis. Next, from the point of view of management, you see there are a lot of management, but the patient is in front of you. You find a lump which is about, maybe you have described as a 6 or 7 or 8, 10 centimeter lump. In that case, you know the size. So it's not that now you have a choice of saying, if it is small, I'll do that, will I do that. So if it is a cyst of this dimension, you are getting a patient in front of you and you take the history properly, you might find that this patient now has come to the surgical ward. So this patient might have received some conservative treatment and now being referred for surgical treatment. So in that case, your approach will be that this cyst being of this size and imaging will give a better idea about what the size is. In that case, you have to choose treatment. If it is a clear cyst, CL or CE1 or even 2, you can attempt for PIR. That is now the standard of care for hydatid cyst treatment. So in that case, PIR plus the albendazole therapy. Now, if you consider surgery, again, now you have the option of laparoscopic and open surgery. And surgery, you have number of options. So you choose a particular option. I think in the exam, it will be safe. You say that you'll do a partial cystopericystectomy. And I can ask few questions to the other people sitting here. Milind, if you have a hydatid cyst cavity and you have removed the partial pericystectomy and there is a cavity left behind, how do you tackle the cavity following this cyst excision? What are the different options when you have a cyst cavity?
And no marsupialization.
Marsupialization is not to be done. That is not the first answer. Marsupialization is done in very selected cases when the cyst is infected. Marsupialization gives the cyst exposed to the exterior. That is not the usual recommendation. The recommendation is you can obliterate the cyst cavity by taking deep stitches. That is known as capitonage. Second is you have to exclude whether there is any cystobiliary communication. How do you exclude during surgery? While doing surgery, how will you exclude that, yes, this is a cyst having no communication of the biliary tree, or there is a communication of the biliary tree which is a minor communication, or it's a major communication? How do you do that? What is the finding during surgery if there is a cystobiliary communication?
After development, there will be a bile.
Before development? Yes, not even leak. Once you start aspirating, hydrated fluid is what? Like watering. It's colorless.
Yes.
If you aspirate, you find the fluid is bile stained, there is suspicion that there is a communication. Number one. Number two, once you open up the cyst, take the part of pericyst, you put a gauze piece. You put a gauze piece in the cavity and see whether the gauze piece is getting stained with bile or not. That is one. If you find there is a small point of leakage, in that case, you can manage it by a simple suture. If you find there is a large opening and you can confirm the cystobiliary communication by doing a contrast study. You inject a contrast into the cyst and you can see the biliary tree. So you find a major communication, what should be your management? Minor communication is managed with underrunning of this radical, and major communication should be managed by?
So we have to isolate that duct and then
no, the recommendation is if it's a major communication, you should do a pericystojejunostomy. That means it's a major leak. If you put a drain and come out, it will keep on draining bile. So the treatment will be a pericystojejunostomy. You drain it to a rule loop of jejunum. Okay. And what is the indication? Why do you give albendazole therapy in a patient having hydatid disease? What are the idea of giving this anthelmintic therapy? Number one is it can be therapeutic. If it is a type 1 or type 2 cyst, it can be therapeutic, particularly if the cyst size is less than 5 centimeters. So the only treatment may be just a drug therapy. Second is if you have a larger cyst, you need to give the patient albendazole therapy free of. Why? What prophylaxis? How it acts? Number one is if you give this patient free of albendazole therapy, this cyst, they say, become non-infective. This kills the scoliosis. So even if there is some spillage during surgery, patient will not develop diffuse pregnant hydronephrosis. So this pre-op therapy is helpful. Number one, it can be therapeutic, or number two, while doing surgery, there is a spillage, it will prevent the diffuse hydronephrosis in the perineal cavity. And third is, as Dr. Dey has said, there are some situations where the disease may relapse in the post-op period. And one explanation for relapse following surgery is, as the cyst grows in the liver, most of the daughter cysts formed by in-pouching into the cyst cavity. There is a concept which said that there may be some exophytic pouching of this endocyst. And while doing surgery, these exophytic components may be left behind. So, if you give the patient immunotherapy in the post-op period, this can be taken care of. So, that is the role of giving the patient anthelmintic therapy. Okay. And while doing pair, as Dr. Day has said, now there is some recent advancement that in pair it was just aspiration and injection. Now there are some system where you can introduce a cannula inside the cyst cavity. You can even aspirate the cyst wall by just percutaneous approach. So these are more recent advancements in management of this hydatid disease. But what I'm saying is, in the exam, you find this patient in front of you, you should be confined to the particular patient you are presenting, and then don't try to give all these unnecessary things that is a cystic swelling. I can appreciate fluctuation. I can appreciate hydatid things. They are not recorded at all. And then there are some indications for doing CT scan. If you have a single cyst, a clear cyst, CT scan may not be essential. When you need to do CT scan, and you should not do the complete treatment without doing a CT scan. What are the situations?
So when we are suspecting a large cyst, that is
One is multiple cyst. If you have a suspicion of a malignant variety of hydatid disease, if it is a recurrent cyst, if it is a recurrent cyst, and if the cyst is complicated, that means it's causing compression, it is causing obstructive jaundice, so you need to do this. There is a cystobiliary communication, and the cyst has ruptured into the biliary tree. What will happen to this patient? The cyst has ruptured into the biliary tree. What will be the presentation of this patient? Cholangitis. So patient will have all the classic feature of cholangitis: fever, pain, jaundice. What is the management? Patient has got cystobiliary communication, and this cyst has gone into the bile duct. What should be the optimal management?
Sure, like bile duct exploration.
Exploration all the time. Now, you see, you have now some modalities of treatment. If the cyst has ruptured into the biliary tree, patient is having cholangitis, doing surgery at the stage of the cholangitis will be risky.
Yes.
There is a role for doing ERCP. If you do a ERCP, do a good sphincterotomy, you can remove this daughter cyst. They have tried, but if you have a large cyst in the liver, it will continue to drain this cyst into the biliary tree. You might need surgery, but initially an attempt can be made to treat this patient by ERCP, sphincterotomy, and this part of the cyst extraction. So these are the indications. ERCP is not needed in all patients. ERCP is indicated when you have a cystobiliary communication, patient is obstructive jaundice. In that case, you can confirm that. Okay. Dr. Day has given a good overview. You should take all the points, and depends on examiner how the examiner goes with you. Okay. Dr. Day, you can ask a few questions. They are around. Milind is there, Nitesh, and some other online.
You have asked all the questions that are usually asked. And actually, typically, we do not, in the exams, we do not typically find a typical case of hydatitis. What we find is actually a patient presenting with hepatomegaly with symptoms which are suggestive. So, when the patient presents, it is better to have a differential diagnosis first of the various cystic lesions of the liver, rather than definitely go in for, and then you can say that based on the symptoms, my provisional diagnosis is hydatitis. Now, can anyone tell me what are the other cystic lesions of the liver which mimic a hydatitis?
Well, other thing, because you cannot give there is no specific feature of hydatitis. You can say it's a hepatomegaly and probably it's a cystic lesion in the liver. So you cannot give a hydatid diagnosis because there is no specific symptoms or signs which are typical of hydatid. So what are the other cystic lesions in the liver? Simple cyst. So the commonest is simple cyst. If you talk about cyst in the liver, the commonest diagnosis should be cystic, a single congenital cyst or some simple cyst. Other cyst in the liver? Before hemangioma, hemangioma is not a cystic lesion. It can be a traumatic cyst. There is a liver trauma, and then there can be a traumatic cyst. Other things which may appear like a cystic swelling, but it's not exactly a cystic swelling. Abscess is one, with other features. You see, abscess will be having other toxic features of tender hepatomegaly. It's not that. So it can be a cyst adenoma in the liver. Hepatic adenomas. Maybe even sometimes a hepatocellular carcinoma with cystic degeneration. Necrosis in the center. Okay, so you have to, don't bring a wild diagnosis. If in the exam you say it's a hepatomegaly and some swelling in the liver, don't bring a diagnosis of retroperitoneal cyst. Don't be a diagnosis of pseudopancreatic cyst. So you have given a, clinically you have oriented this is a liver mass. So keep your diagnosis pointing towards the liver mass. Is it, Dr. De?
Yes, sir.
I don't think they should bring a retroperitoneal cyst or a other cyst, mesenteric cyst, because you have already given that this is a swelling which is into the liver and likely a liver. Now, if you are not sure about the liver swelling, yes, you can put other diagnosis. But once it says liver, stick to some liver differential diagnosis.
Another thing is sometimes, as sir said, that it could rupture into the common bile duct. There are other areas also where it could rupture. Like suppose it can rupture into the pleura, it can rupture into the bronchus. So all these are other potential sites where the hydatid cyst can rupture.
How this patient present if there is the intraperitoneal rupture? One of the complications of hydatid cyst is intraperitoneal rupture. So what is the presentation? First is anaphylaxis. So if there is intraperitoneal rupture, some of the patient can present emergency with anaphylactic shock. Because of this antigenic reaction, patient anaphylactic shock, that is one. Second is, as the hydatid fluid is getting contained in the peritoneal cavity, it can cause classical signs, symptoms of peritonitis. Pain abdomen, which becomes generalized, rigidity, then tachycardia, all other features of peritonitis. So it can be a simple case of peritonitis where it is difficult to make a differential diagnosis. So it can be classic features of peritonitis. What is the treatment? You have suspected that now you find the imaging, you find yes, there is a hydatid in the liver and that probably has ruptured and patient in peritonitis. What should be the treatment? Treatment for rupture hydatid with peritoneal contamination. First is resuscitation. As I say, these patients are in shock. Patient who has got a rupture in the peritoneal cavity, the first is resuscitation. And if you find there is an associated cyst in the liver which has ruptured, surgery is mandatory. In that case, it can be either a minimal invasive surgery or open surgery. Because if the cyst is ruptured in the liver and is all continually excluding this cyst, we should do surgery. So initially resuscitation and then followed by surgery. So you do a peritoneal lavage with sclerocidal agent and tackle the primary cyst which is ruptured.
Actually, these when they rupture, they typically present with as like hypersensitivity, type 1 hypersensitivity. So you have to manage in the lines of that first, optimize the patient, and then, as I said, you can then go in for surgery and manage the rest. If the patient has features of gross peritonitis and if you find that there is evidence of peritonitis with sepsis, so then first you optimize the patient because of that allergic reaction, stabilize the patient, and then take the patient out.
Nitish, what is the treatment for a calcified cyst? You do imaging and you find there is a type 5 cyst. What is the treatment for type 5 cyst?
Type 5
Actually, type 5 cyst uses calcified cyst, usually described as dead cyst. In that case, only surveillance. He did not give also albendazole therapy in that situation. A classically solidified calcified cyst described as cyst is inactive. In that case, no treatment is required. You should do surveillance. Okay, Dr. De, we have discussed the main part of this treatment.
Means during MS exams, all of you will face hydatid cyst. Even if you don't get a case history, there are specimens, there are ultrasounds.
Yes.
Somewhere or the other, you will encounter hydatid in your whole journey of the MSI. So,
And one should be very conversant with the structure of adult worm and how the hydatid cyst develops. Once the intermediate host ingests this ovum is covered by a chitinous shell. And once this is ingested, this chitinous shell is digested in the stomach and it liberates a hexacanth embryo. There are 6 hooklets. This hexacanth embryo burrows through the duodenal wall and then enter into the portal circulation. Once in the portal circulation, as it goes to the liver, these hooklets are shredded off. And this ovum having a membranous wall is the primary structure which is forming the hydatid cyst in the liver. And Dr. They already described that this forms the germinal epithelium. And this germinal epithelium secretes some proteinaceous material which form ectocyst. Ectocyst creates a host reaction with fibrosis that forms the pericyst. So these are the 3 layers of cyst which comes up. So you should be very conversant and it should be able to describe how a cyst develops and how adult worm develops. These cysts are in the sheep. And as the sheep is dead, these offals are discarded and dogs eat. And what dogs eat? Dogs eat the hydatid cyst itself. And hydatid cyst contains what? The daughter cyst, and inside them the scoliosis. As the dog ingests these hydatid cysts, again these are broken in the stomach and the scoliosis are liberated. This scoliosis goes to the duodenum and the small gut and they get stuck to the mucosa of the gut and start developing. How many segment adult worm has? A classical Echinococcus granulosum adult worm has how many segments? Huh? Is it got a head with scoliosis? It has got a small segment described as neck and it has got 3 to 4 segments. What is the characteristic of the last segment? What is the characteristic of the last segment of the cyst, adult worm?
what is it
That is
known
very
as?
important.
There is a physical name for the last.
Yes. That is a gravid segment, which contains the mature ovum. And once this adult worm is coming up, the last segment is broken. And the whole large segment is going out. As it goes to the gut, it gets disintegrated. And ultimately the ovum is covered by the chitinous shell. There is a shell around the ovum. And this membrane with the hooklets are inside that chitinous shell. And chitinous shell is a structure which is lying outside. Otherwise, it would have been damaged in the exterior. Okay, so this you should be knowing the adult worm and then how the adult worm is liberating the eggs and how eggs are being ingested and then eggs forms the hydatid cyst. Okay, so you must be very conversant about the newer classifications and this. You see, economic multicolority is not a very common disease you come across in your day-to-day practice. It's a more rarer disease than the common cystic disease. Thank you, Dr. De. I think we can conclude. Any question? Nobody has put any chat. Oh no, that okay.